2 million people around the world suffer this disease every year. 40% of the patients that new diagnosis with lung cancer are stage 4. Non-small cell lung cancer is not one disease. There are a lot of diseases, at least 5 diseases. We have different outcomes.
Ladies and gentlemen, welcome to our specialist podcast series at MedSynapse. Today, we're honored to have a distinguished guest with us, Dr. Cristian Buono, a brilliant medical oncologist from Argentina and currently a doctor in Dubai, making important contributions to cancer treatment. With an impressive background spanning over 20 years of experience, Dr. Cristian has been a key contributor to the progress of cancer treatment. His notable skills are especially evident in the areas of solid tumors and uncommon cancers. Notably, he led a team of 15 experts in phase 3 research focusing on breast and lung cancer. Currently, Dr. Cristian also holds the position of Principal Investigator for Oncology Research Clinical Trials at the Mar del Plata Medical Research Center in Argentina. His wealth of knowledge and experience makes him the perfect guest to delve into our today's topic of discussion, advanced non-small cell lung cancer. Welcome, Doctor.
Oh, thank you. Thank you very much, Dr. Nicar, in behalf of MedSynapse, to invite me and introduce me to this interesting topic that we are going to discuss today of non-small cell lung cancer. So I feel free and be confident to ask any question, what you want to know about advanced lung cancer.
Thank you so much for being with us here today.
You're welcome.
Before we begin, I would like to ask one personal question. What motivated you to specialize in oncology and dedicate your career to helping cancer patients?
Oh, well, this is a interesting question. My father was an oncology first. My father died 25 years ago, but he inspired me in this disease, stimulated me to back in days to study this disease. So I have parents that suffer for cancer, breast cancer, and lung cancer also. So back in days, I have the curiosity to know how can I help these people to suffer this devastating disease, right?
Thank you, Doctor, for sharing your inspiring journey. I'm eager to continue our conversation and explore the insights you have to offer on our topic of discussion today.
Already.
Perfect. To start off, Dr. Cristian, could you provide an overview of the current landscape and prevalence of advanced non-small cell lung cancer?
Oh yeah, sure. That's a good question. I want to say some tips, some topics about the disease. 2 million people around the world suffer this disease every year. 40% of the patients that new diagnosis with lung cancer are stage 4. Stage 4 disease means that the tumor escape the chance of cure and go outside the lungs or the thoracic zones. Lung cancer, we have two types of lung cancer. Non-small cell lung cancer, that is 80% approximately of the cases, and the other 20% is small cell lung cancer. Today we are going to talk about non-small cell lung cancer, that is the most frequent variation. Although cigarette smoking is the high risk factor for develop lung cancer, the majority of lung cancer are in non-smoker people or little smokers. So smoke is a very important issue here. We have some type of non-small cell lung cancer. For example, adenocarcinoma is the most frequent subtype of non-small cell lung cancer. Squamous cell carcinoma, large cell carcinoma, and neuroendocrine tumors. That this is the combine of tumors that we are talking about. Only a few percentage of patients are alive at 5 years of diagnosis. It depends on several factors that we are talking later. This is a very interesting disease because not a healthy problem. It's about economic and financial issue as well. Eligible patients should be considered for clinical trials every time we have the chance. That is because if the patient can join to a clinical trial, have the most chance to receive all the drugs available for this disease. So this is a very important issue also.
Now let's go a bit deeper. How have the ways doctors figure out advanced non-small cell lung cancer changed over time, and what important things help them decide if someone has it?
Okay. If you see the mortality rate 2 or 3 decades, we see that the mortality rate is going down. That is for two reasons, I think. One reason is that the people are smoking less. Um, the people get the advice to less smoking, and the other factor is the screening. TC screening with low doses of radiation show that mortality rates fall down. So I think that these two important um, issues are the start to see the mortality rates going down, right? Also, I can add that new treatment, for example, immunotherapies or target therapy, the era of personal treatment is in Ausch. So this is the three most important issues for the mortality going down.
Moving forward, when it comes to treatment, what are the primary modalities for advanced non-small cell lung cancer, and how do you navigate the personalized treatment journey for individual patients?
Yes, it's very interesting question. Nowadays, the primary diagnosis of lung cancer or any type of cancer is pathological diagnosis. That is mean we have to make a biopsy of the tumor. When we talk about lung cancer, we prefer always talk with pathologists. We prefer tissue than cells, right? Because we need to do a lot of we need to do a lot of tumor genomic change, the mutation. I refer to that, and we need tissue better than cells, right? Nowadays, I can say that non-small cell lung cancer is not one disease. There are a lot of diseases, at least 5 diseases. We have different outcomes. For example, patients that have a different mutation, HCPR, for example, ALK mutation, or BRAF B600 mutation, for example, and they have different prognosis and different way to evolve, right?
Dr. Cristian, thank you for sharing your expertise and insights on the multidimensional nature of treatment. Definitely, each patient is different, and we need to balance the medical knowledge with what's best for the patients. Moving on to the next question, let's explore treatment strategies further. How do you effectively combine chemotherapy, targeted therapies, and immunotherapies to create a comprehensive plan for patients with advanced non-small cell lung cancer?
Yes, thank you. This is a very interesting question. The first approach to the patient is look at the performance status. It means how is the patient are. Um, After the diagnosis of non-small cell lung cancer, we must to check the mutation status. This is very important because if the patient have any mutation, have the best chance to get a better overall survival. If the patient have no driver mutation, we have chemotherapy to offer to the patient. For example, if the patient don't have any driver mutation, we offer chemotherapy, platinum-based chemotherapy, doublet platinum chemotherapy, with bevacizumab if the patient don't have history of cough with bleeding or any cardiovascular disease previously. For example, this is an example. If the patient have any of the mutation that we know, for example, epidermal growth factor receptor mutation that it accounts for 20-25% of the patient, we have a lot of drug to offer, a lot of treatment to offer this patient. For example, TK inhibitors, second generation, osimertinib, for example, dacomitinib, for example, or afatinib, have show better progression-free survival than TK inhibitors of first generation, gefitinib or erlotinib. This is an example. Another example could be ALK translocation that account for only 5% of the patients. Here is the same. Second generation is better than first generation TK inhibitors. Here we have alectinib, lorlatinib, or seritinib that are better than brigatinib or quizartinib. This does change the way that we see lung cancer patients. BRAF, for example, BRAF's B600 mutation that account for 1 or 2% of all non-small cell lung cancer. We have dabrafenib and trametinib that shows this drug, this combination shows 64% response rate. Only we have data for phase 2 clinical trials. ROS1 is another mutation driver that we have entrectinib and crizotinib also. This mutation show better results that the patient that don't have any mutation. If we going forward, we can check the expression of PD-L1. Here we introduce the checkpoint inhibitors, that mean immunotherapy. Here we have 2 or 3 drugs, for example, pembrolizumab alone or pembrolizumab plus chemotherapy. It depends on the expression of PD-L1. And atezolizumab is the other drug. So we have the landscape here show that it's not a devastating disease at all. We have the chance to get a long, better overall survival if we compare to 10 or 20 years ago.
Moving on, are there any emerging therapies or experimental treatments on the horizon for advanced non-small cell lung cancer that fellow doctors should have on their mind?
Yeah, absolutely. Every time we can check the National Cancer Institute clinical trials. You can, if you the website, if you look there, you can see the clinical trial that are try with different drugs and different new drugs and different scheme of therapy. For example, 2 drugs, 3 drugs, or 1 drug. So for this one, I recommend all people, medical and non-medical people, to check the website of National Cancer Institute and we'll see what you can see there, what kind of clinical trial are open to join a patient if we have it.
Addressing resistance is crucial. Could you share your strategies for managing resistance and disease progression in advanced non-small cell lung cancer?
Yeah, absolutely. Sooner or later, unfortunately, all the patients are become resistant to therapy. So at that time, when the resistance overcome, we need to see the patient, to see the performance status, to see. We need to know how the patient feelings, what to prefer, quality of life, and the chance and the prognosis that the resistance see and how to overcome the resistance. But sooner or later, unfortunately, all the patients become resistant to treatment. So we need to change at this point. We need to change the treatment only. So that is why we encourage all the patients to join to clinical trials, because the more exposed the patient to all drugs, more chance to better overall survival and quality of life.
Dr. Cristian, shifting our focus, could you elaborate on the role of liquid biopsies and molecular testing in monitoring treatment response and detecting resistance early in advanced non-small cell lung cancer cases?
Yes, Dr. Nicaro, very good question and very interesting. When we talk about liquid biopsy, we refer as cell-free DNA. That means a fragment of DNA that is fluiding is going to the bloodstream. The process of liquid biopsy is non-invasive. Accurate interpretation is still a challenge, unfortunately. And I say that two main roles for liquid biopsy or seal-free DNA. Monitoring early response, that is very important, but most important, the detection of resistance. The leading example here is the T790 mutation in epidermal growth factor receptor mutation patients, right? I think that it's not the standard of care right now, liquid biopsy, but it's going to be one day, for the point that I mentioned previously. It's better to have a liquid biopsy instead of try to do a new biopsy to the patient, right? So, but the interpretation is still a challenge right now, and not the standard of care in many parts of the world.
Now let's circle back to patient interaction. When discussing treatment options and prognosis with advanced non-small cell lung cancer patients, what key considerations do you prioritize?
Well, it's a very nice question. So I think that when you approach the patients with the best strategy, we must consider preference of the patient, right? Preference, for example, oral preference versus intravenous chemotherapy, side effects, for example. Most of the people, for example, don't want to lose the hair. This is important. You say, okay, but hair is not important. No, hair is important for the patient, and we must to consider it. Quality of life, toxicity for the previous treatment. All of these issues must take account for decide what's next, what the next step, right?
Now, finally, to wrap up, what message or advice would you like to share with the fellow doctors on the front line of treating patients with advanced non-small cell lung cancer?
Right. Well, I want to share a message. Advanced non-small cell lung cancer, like other kind of tumors, is not a terminal disease, right? We have a lot of line of treatment that convert not curable disease to chronic disease with better quality of life. So chemotherapy, immunotherapy, or what else, convert, transform disease that is not curable to a chronic disease that the patient could live several years with good quality of life. That is one of the most important issue for the patient and for the doctors also.
Thank you so much, Dr. Cristian, for sharing your expertise and shedding light on this important topic of oncology. We're truly fortunate to have professionals like you at MedSynapse who are dedicated to making a positive impact on healthcare.
Thank you, Dr. Nigar, and hopefully see you soon and meet you soon also. Thank you very much.
And to our listeners, we encourage you to stay connected with us for more engaging discussions that enrich our understanding of medical advancements. Until next time, take care and goodbye.
Thank you very much. Goodbye.
If you're looking for a community where you can engage in meaningful conversations about medicine and contribute to the advancement of healthcare, I highly recommend checking out our MedSynapse platform.